Hello, I'm excited to introduce you to my research, New Horizons in the Treatment or Prevention of Cystic Fibrosis-Related Diabetes. I'm Anca, I'm a pneumology medical resident student and a first-year PhD student. And along with my team, we have a vision that all cystic fibrosis glucose metabolism is set to the best level we can achieve. The work is driven by a mission to find a therapeutic method which stabilizes glucose metabolism and also improves lung function. For that, I have two specific goals. The first one is investigating the effect of insulin therapy in cystic fibrosis patients, and the second one is investigating the effect of triple transmembrane regulator therapy on cardiometabolic parameters in cystic fibrosis patients. So let's start with the first one, investigating the effect of insulin therapy in cystic fibrosis patients. Cystic fibrosis is the most common autosomal recessive disorder in Caucasian, and due to increase in life expectancy, previously rare complications are now coming to light. And the most common of all is cystic fibrosis-related diabetes, which affects 40 to 50% of these patients. Diabetes is associated with increased morbidity and mortality, and in CF, one of the most important factors that determine patient outcome is lung function. So my aim is to investigate the effect of insulin therapy on lung function in cystic fibrosis patients. For that, a clinical question was born. What is the effect of insulin in cystic fibrosis on lung function? We used PICO framework. For the population, we followed cystic fibrosis patients receiving insulin, and we're looking on the lung function and BMI before and after therapy. My hypothesis is early glycemic control with insulin improves lung function and quality of life in cystic fibrosis patients. That will lead to administration of insulin in CF patients that can increase survival and improve clinical outcome. We conducted a systematic search in 5 databases with a search key contained of 2 domains, the first one regarding the disease and the second one the intervention. And along with my co-investigator, we're down to 20 eligible articles. We conducted a meta-regression analysis assessing the effect of insulin on lung function and BMI in cystic fibrosis patients. We analyzed the FEV1 change follow-up versus baseline, which is a key marker of lung function and disease progression. FEV1 means the percentage of normally expected lung function for a person's age, sex, and height. And it ranges from 0 to 120%, with a normal interval from 80 to 120, and below 40, it's considered severe impairment. So clinically, a declining in FEV1 means worsening lung function and a higher morbidity risk. Our analysis included 20 studies with approximately 1,000 patients examining the impact of insulin while adjusting for glycemic status, diabetic versus non-diabetic, follow-up time, and baseline values. The data was collected from interventional and observational studies. And here we can see that the model estimated approximately 7% lower FEV1 change in diabetics versus non-diabetics, but wasn't statistically significant, while follow-up time and baseline FEV1 were the main predictors for lung function change and the main drivers for variability across studies. We can visualize those results in these 2 charts. We can see that the change in FEV1 is decreasing over time, and there is no difference between pre-diabetic and diabetic group as the confidence interval are overlapping. And this means that the change in FEV1 for patients with cystic fibrosis and abnormal glucose metabolism is influenced by follow-up time and baseline values. And while we can isolate the effect of insulin itself, the fact that there are similar trends between these 2 subgroups highlights the progressive nature of cystic fibrosis. We conducted the same analysis for BMI, BMI Z-score, which is the main nutritional factor adjusted for age and sex. BMI Z-score, or BMI standard deviation score, means how far a patient's BMI deviates from a standard reference population. And it ranges from -3, which means severely underweight, to +3, which means severely overweight. And the normal range is between -1 and +1. We can see here that none of the included predictors show a statistically significant effect on BMI Z-score change across studies. Also, we can visualize that here, no significant variation between BMI Z-score baseline versus follow-up. Again, then, there is no difference between pre-diabetic and diabetic patients. This means that it's most probably that nutritional status is influenced by broader other factors in cystic fibrosis. So this is my progress. We are planning to do a random effect analysis on this also, maybe to have more answers to our question. The second one of my studies is investigating the effect of triple transmembrane regulator therapy on cardiometabolic parameters in cystic fibrosis patients. As I've mentioned, CF is the most common genetically lethal disease in Caucasian people. And for the most common mutation globally, since 2020, the standard of care is this triple therapy, shortly called ETI therapy. A significant weight gain was observed in these patients, and 90 to 25% of people with cystic fibrosis are now classified as overweight, and 6.6 to 11% as obese. This starts a vicious circle because they develop derangements in glycemic and lipid control due to increasing weight and age, and by the age of 40, almost half of them develop cystic fibrosis-related diabetes. Some studies show that 60% of these patients had hypertriglyceridemia, and increased blood pressure becomes more apparent. And since 2021, 7.2% of these patients were classified as having hypertension. My aim is to investigate if ETI therapy has an effect on cardiometabolic parameters and slow down this vicious circle. My clinical question is, does ETI therapy has an effect on cardiometabolic parameters in cystic fibrosis patients? We also use the PICO framework. We're looking into patients who are receiving this triple therapy before and after it, and we will assess these parameters: BMI, weight, blood pressure, HDL, and triglyceride. My hypothesis is ETI therapy may increase the cardiometabolic parameters. The clinical implication will be that in the context of longer survival and increased prevalence of overweight, it is thus important to assess cardiometabolic risk. So to summarize, I have two ongoing projects. The first one, I hope I will finish soon and submit it, and then go further with the second. And I would like to end my presentation with the quote from Nelson Mandela: "It's also seems impossible until it's done." Thank you.
Thank you for the very clear presentation. Is there any question from the audience? Yes, please.
So it's regarding your first project, is that as far as I know, when you start initiating insulin, the FEV1 becomes a little bit decreasing. So is there any explanation for that?
You are referring to my my first
yes.
chart. Okay. So the fact that the change in FEV1 is higher in the beginning of the treatment and then changes and lowers, it's because of the effect of insulin, because the infections are lowering, and it has an effect on muscle, and the respiratory muscles are getting better. And then in the end, the disease progression will show up, and the lung function will slow down.
More question?
Congratulations on your presentation. I saw statistically you adjusted for 3 things. Any reason for those in particular? Was there anything else you considered?
Yeah, we consider a lot of predictors like insulin type, insulin regimen, infections, steroid use, and so on. But in the end, only these 3 made sense. These 3 are the most clinically relevant of them all. And we also were looking in the others, but we did a sensitive analysis on them.
Thank you.
Welcome.
Questions, please? Can I ask something?
Yeah.
That do you have any idea, based on the literature, the occurrence of a liver disease in a CF patient? What's the approximately prevalence of a liver disease?
I haven't looked into liver disease specifically. I'm sorry.
And the frequency of obesity of a CF population is nearly the same as in the general population. There was a slide about it.
No, it's increasing only in this population because until this triple therapy, this effect, it wasn't observed. Only in the latest years it appeared, and apparently it becomes a problem, and these patients are going to be overweight.
Okay, because I have a suggestion, if you have chance for that to examine the presence of fatty liver or steatotic liver in the CF patients, because it could be a cardiological risk factor.
I've seen it mentioned in some studies, but it's not ongoing very.
Okay.
We will look into it. Yeah.
Suggestion. Okay. Thank you.
Thank you.